Hi, my name is Lionel Bouchet. I'm here with Dr. Mathew Poppe from the Huntsman Cancer Institute. Thank you, Dr. Poppe, for joining us this afternoon to talk about proton therapy and your experience.
Yeah, you're welcome. Good to be here.
Thank you. So, Dr. Poppe, can you tell us a little more about the Huntsman Cancer Institute?
Sure. Yeah, so the Huntsman Cancer Institute is located on the campus of the University of Utah. We are one of the National Comprehensive Designated Cancer Centers, and we actually serve the largest geographic region of any of the comprehensive cancer centers in the U.S. So we serve most of Montana, Idaho, Wyoming, Utah, and parts of Colorado and Nevada.
Okay. So you recently, I think about 8 months ago, started with proton therapy. How did you integrate, how did you bring proton therapy in a Huntsman Cancer Institute?
Yeah, so based on that large geographic region that we serve in the Mountain West, there was no proton resources within about a 12-hour driving distance from our center. And it really became clear due to the increasing role of protons and the data supporting the safe and judicious use of protons that we needed to bring protons to the Mountain West. Our patients were traveling great distances to receive proton therapy. And we really felt that as a National Comprehensive Cancer Center, we really needed to bring that and have that available for our patients. We do consider it a precious resource. Only about 10% of our patients right now are treated with protons, and we triage patients that have the highest need and those that were already leaving state to receive this therapy.
So what indication and what kind of patient are you treating today?
Yeah, as of today, we're treating most of our pediatric patients. We're treating our young adults with CNS tumors, head and neck patients, patients with pelvic or spinal sarcomas, and then a variety of other patients, depending on the tumor location, histology, and whether or not they have recurrent disease.
So how have you trained your staff to be able to deliver this proton therapy treatment?
Yeah, so we started the process several years before installation, hiring and training additional physicists and dosimetrists first. And then the dosimetrists and physicists helped train the MD faculty. We have 13 MD faculty on site. And one of the real benefits of the Mevion system is that we were able to build it on our main campus. And so it's a resource, it's a tool that all of our MD physicians can use regardless of the diseases that they treat. And so we've trained all of our physicians to be comfortable both evaluating IGRT images, but as well to create proton plans in patients they feel it's appropriate.
So you have staff specialized in proton therapy, or are you cross-training between photon and proton therapy, your staff?
So all of our staff are in the process of being trained and being competent on the use of creating proton plans. All of our staff understand the physics of protons, can evaluate image guidance images to know whether or not patients should be replanned or potentially not treated. And then as we advance through more complex cases and we start treating more disease sites, we are eventually incorporating all of our staff physicians who will be utilizing proton therapy.
So what kind of imaging are you using for every day to localize the tumor from an IGRT standpoint?
Sure. Yeah, so the most common is a KV orthogonal pair. And we use those especially for tumors that have been resected. There's no gross disease. We don't expect changes in the anatomy, and the tumor can be identified in proximity to bony structures. And so this is quite common, especially for brain tumor patients and head and neck patients. We have available CT on rails, which we have found to be really invaluable for anyone that has gross tumor or whose tumor is not in relation to bony anatomy. So we can visualize soft tissue components with diagnostic quality imagery. And we can we can reconstruct the dose data on the CT on rails imagery. And so when the radiation oncologist called to the machine, they can see right then and there how a change in the anatomy might affect dose deposition.
How do you decide these treatment adaptations? You decide it from a clinical standpoint and maybe physics?
So each, I would say each attending physician decides the IGRT plan up front. What I usually do is I will order a CT on rails for the first 1 or 2 treatments to establish no change in the anatomy from the date of simulation to the date when we start treatment. And then I'll do it at least once or twice a week throughout their treatment. And provided that the anatomy has been relatively stable, I try to use the lowest energy IGRT modality possible. And so I'll often go back to KV ortho pair, especially for my pediatric patients, if I don't need to do daily CT on rails.
When you treat medulloblastoma, do you use X-ray localization or you use CT localization?
So when we treat medulloblastoma, we're doing craniospinal radiation, then followed by a boost. For the craniospinal portion of the IGRT, we use KV ortho pair because we're aligning to bony anatomy. We don't have any gross disease, and so that has worked out really well to verify isocenter and to verify the spine alignment for patients. When we then go to treat the posterior fossa and I want to see the size of the resection cavity, I'll start with CT on rails, making sure that the resection cavity has not changed in size from the time of simulation. And if that's true, then I'll just go back to doing KV ortho pair.
So this multi-imaging technology is very important in your practice.
Very important, very important. And in the few cases where we have wanted to do replanning, we immediately have done the simulation. So that image set obviates the need for another CT simulation. So we take that data set, we send it to our dosimetrist, and we can immediately start on replanning the case.
So what are indications today that you've been treating for pediatric indications?
So I would say almost all of the pediatric CNS tumors, pediatric neuroblastoma, pediatric sarcoma are the cases that we've been using it most common. But there have been a few Wilms cases where for whatever reason, the normal tissue is better protected with Proton. So it's a case-by-case decision for other patients.
So what has Proton brought to you as a pediatric physician?
Well, so I mean, I've been utilizing Protons for over a decade, just not me myself. Like I've had to, when I identify a patient that should be getting Proton therapy, I send them out. And so what this allows is not so much the patient to get something different, because they would have gotten Protons anyways. This really brings the ability for patients to get Protons closer to home. So it's less disruption for these patients. So many of my patients were having to travel 12 hours, move their family, split the parents, and now they don't have to do that. Now they can receive their care closer to home, which makes it better for the patients and better for the patient's family. That's really what this has brought to Utah.
So after 7, 8 months, 9 months of having Protons integrated within your practice, what would be your advice to NCI comprehensive cancer centers, to other NCI cancer centers that are considering Proton therapy?
Yeah, I would say to look at your patient mix and patient volume. I think if you have a high complexity of cases, you have recurrent cases, you have pediatric cases, it's very likely that you could support a single gantry Proton center at your institution. We have not had any problem with insurance for any of our pediatric patients. Most of our young adult CNS and sarcoma patients, we have had no problem with insurance for. And so I really think that a comprehensive cancer center really needs to provide that definitive high technology level of care to patients. And so I think it's the right thing to do for a comprehensive cancer center.
What has Proton therapy brought to you and the Huntsman Cancer Institute from a research perspective?
So from a research perspective, we're just in the process of finishing our credentialing process. So you have to be operational for 6 months to be credentialed by IROC. IROC is the overseeing organization for radiation oncology quality in clinical trials. And so we are now going to be able to participate in many of the cooperative group trials that are specifically looking at proton-based radiation, both through the NRG, through COG, and so we'll be able to participate in those clinical trials with care for our patients. Additionally, it will allow our MD physician to potentially look at other indications and to write investigator-initiated trials that might utilize proton radiation. I think we're also quite interested in flash radiation, and so we'll be interested in adopting some of the experimental flash technology that Mevion is working on to potentially look at good uses of flash radiation as we move forward into the future.
Well, Dr. Poppe, yes, thank you very much for your time today. That's very interesting. I appreciate you sharing your experience.
Well, thank you. It was nice visiting with you.
Thank you.